Good evening, everyone. A warm welcome to the BMC Oncology Webinar Series 2025. The webinar is hosted by Balco Medical Center, Naya Raipur, and is supported by Roche, Intas, and EDLI. The theme for today's webinar is Changing Paradigms in Lung Cancer Management. Our esteemed chairpersons for the webinar are Dr. Bhavna Sirohi, Senior Medical Oncologist and the Medical Director of the Vedanta Medical Research Foundation, Naya Raipur; Dr. Gaurav Gupta, Lead and Senior Consultant, Radiation Oncology; and Dr. Divakar Pandey, Senior Surgical Oncologist at Balco Medical Center, Naya Raipur. Requesting Dr. Sirohi to kindly speak a few words.
Hi, good evening, everybody, and welcome to this webinar on lung cancer. Thank you to the industry partners who are supporting this meeting. From when I used to treat lung cancer to when it is being treated now, I think lung cancer is hundreds of different diseases, because the way we used to treat almost 2 decades ago is not the way we treat now. The treatment has become so personalized that it's a ROS disease, it's ALK disease, and I'm looking forward to listening to the speakers, especially Dr. Yashwant, to see how we treat lung cancer now in 2025. Thank you.
Thank you so much, ma'am. Let's begin with today's session. I would request Dr. Yashwant Kashyap to enlighten us on the topic, redefining the management of NSCLC with Tecentriq. Dr. Kashyap is a senior consultant in the Medical Oncology and Hemato-Oncology Department of Balco Medical Center. Over to you, Dr. Kashyap.
Thank you, Achal, for very kind introduction. Thank you, Rosh, for supporting this on very important topic of lung cancer. So I hope I am full screen.
Yes, sir, your screen is visible.
So good evening, everyone. Today I will be discussing about the atezolizumab monotherapy in first-line metastatic NSCLC patients. So as ma'am said, that lung cancer treatment has evolved over years. Earlier we were expecting the life expectancy of only 6 months around. Now things have changed very remarkably, and now we have many things in our options. But there is one subgroup where EGFR ALK negative patient, they are the patient where options are still very limited until this wonderful drugs of immunotherapy. So these are my disclaimers. So I will be discussing about the IMpower 110 trial, which is a first line trial for metastatic NSCLC patient, either non-squamous or squamous. We know that in our practice, more than 90%, 95% patient are stage 4 patients. So this is very pertinent population. They all patients were chemotherapy naive. They were PDL1 selected patient, which I will show you over next slides. They were EGFR ALK negative. Then they were stratified based on gender, ECOG, histology, then PDL1 expression. And there were 572 patients. They were randomized 1:1 ratio in atezo monotherapy versus the standard chemo. Standard chemo we use for non-squamous is as we use pemetrexed carboplatin. For squamous, we give gemcitabine carboplatin. Then these patients were given induction chemotherapy or in other round immunotherapy for 4 to 6 cycles, followed by maintenance doses. And immuno was then continued till progression. So primary endpoint was OS in wild type population who were EGFR ALK negative. Secondary endpoint was PFS, overall response rate, and duration of response. So what are this TC1, TC2, TC3? So TC1 were patient with tumor cell, like you all would have seen that in OPD we order for PDL1 testing and CPS scoring. So TC is for tumor cells. It is categorized in 1, 2, 3. So 3 means if PDL1 is more than 50%, 2 is more than 5%, and 3 is population where it is more than equal to 1%. All this percentage distribution is important because trial which have taken atezolizumab as drug, they have categorized. like IC1 with 3 means more than 10% of immune cells, 2 means more than 5%, and 1 means more than 1% of immune cells. So patients were divided into two groups, based on TC unselected, like arm A and arm B. Arm A was Atizo alone arm, and arm B was chemo arm. So both the groups were equally matched for age, male, white population, or Asian, or non-tobacco users. So around 13% patient were non-tobacco users, and non-squamous histology was around 69%. In our population, this percent is more than 90% of our patient are adenocarcinoma. And PS was PS0 patient were also there around 35%, which we hardly have PS0 patient in our population. So regarding the main population where the immuno has main role, like this TC3 population, which I explained, that patient with the PDL1 population, PDN percentage more than 50%. These patient, there were 107 patient in atizo arm and 98 patient in chemo arm. So regarding, and this landmark study has reached its OS point, though as we know that in immunotherapy, this curve starts separating, and patient who generally respond, they respond for longer time and for durable period. 6-month OS with atizo was 76.3% compared to 70.1% in chemo arm. 12-month OS was 64.9 months percentage compared to 50.6, and hazard ratio was 0.59, which was significant, and median OS in atizo arm was 20.2 months compared to in chemo alone arm was only 13.1 month. 1 month. And as we know that we can see in this curve, the typical immunotherapy phenomena, that patient who respond, they generally respond for longer period. That's why we tend to continue immunotherapy for longer period. Regarding the improvement in PFS also, we know that lung cancer is a very aggressive disease, and our 6-month PFS in atizo arm was 60.3% compared to only 38.3% in chemo arm. PFS was only 8.2 months, 5 months, only 5 months in chemo arm compared to 8.2 months in atizo arm. And this typical phenomena, that if patients does well for initial month, then he respond for immunotherapy for longer period. So initial period was important. After that, there is a remarkable separation in curve compared to chemo alone, and hazard ratio was 0.59, which was statistically significant. Regarding the response rate also, the atizo arm has done better with 40.2% compared to 28.6% with chemo alone arm, and CR and PR were also more and better with atizo arm compared to chemotherapy arm. So in a TC3 group, which are patients who are having PDL1 more than 50% or immune cell percentage of more than 10%, their immunotherapy of single atizo has done markedly well compared to chemo alone. And these are the different OS benefit which was analyzed over different platform. We generally in different trials, atizo trial has used SP142 platform, but even in other platform like 22C and SP263 also, atizo has shown superior compared to chemotherapy. In all these platforms also, median OS was better with atizo compared to chemo alone. So it has done better in across. So it can be used in across the patients also. Regarding the side effect profile, there was no new safety analysis, new safety indicator with atizo compared to chemo. In our practice over last 10 years, we are using immunotherapy. So now we are more wiser with side effects of immunotherapy regarding autoimmune side effect, like hypothyroidism. So all these side effects, now we are more able to manage it better. So there was no new safety signals, and grade 3 side effects were almost even more in chemo arm compared to atezo alone, and immune side effects were more in atezolizumab arm, uh, which we have seen in our practice also. The typical side effect of anemia, nausea, neutropenia, constipation, everything was more in chemotherapy arm. But the typical immune side effect like rash, pharyngitis, arthralgia, pruritus, hypothyroidism, they were more common in atezolizumab. And all this we have, and even in updated safety analysis also, it was similar also. So there was no safety indicator. So, to summarize regarding atezolizumab single agent in lung cancer, IM Power 110 is a positive study which has demonstrated very statistically significant and meaningful OS in TC3 or IC3 wild type population. TC3 means patient with PDL1 more than 50%. IC3 means PDL1 more than means immune cells more than 10%. So all these populations, atezolizumab is better than platinum-based chemotherapy with hazard ratio of 0.59, which was statistically significant. And it has shown that in this population, it has shown meaningful improvement in PFS, overall response rate, and longer duration of response compared to chemotherapy. And safety profile of atezo was also very much comparable, and there were no new or unexpected safety signals identified. So we can say that it is a one of for patients who are EGFR ALK negative or other driver mutation negative patients with PDL1 and TC score and IC score 3, they are the ideal candidate for atezolizumab monotherapy for our patients. So now with this, that's why it is now standard that for our patient we should be doing the NGS broader panel NGS in baseline, so that we can give the maximum benefit of our targeted and immunotherapy to our patients. So with this, thank you everyone for patience listening.
Thank you, Dr. Kashyap, for your insightful presentation. Next, we move on to our case-based discussion on EGFR ALK negative NSCLC. The session will be moderated by Dr. Anshul Agarwal from Aviva Cancer Center, Surat. I request Dr. Agarwal to also introduce the panelists for the discussion. Over to you, sir.
So good evening. So myself, Dr. Anshul Agarwal, medical. So Dr. Rakesh is there, Dr. Preeti is there, Dr. Yashwant is there. Dr. Somnath has not joined yet. So can we go ahead?
Dr. Somnath is joining in a minute.
Okay. So my slides are visible?
Not yet, sir.
Yet.
It is visible now, sir.
With bevacizumab. So both of these three studies we will discuss in detail. So my first question with the panelist, Dr. Rakesh Mishra. So which predictive biomarker for cancer immunotherapy you use before starting immune checkpoint inhibitor to a patients?
So regarding the immunotherapy, I do prefer the PDL1 testing, and regarding the platform, I'm usually comfortable with the both, that is the SP263 and SP142. But yes, definitely, I usually do prefer SP263 compared to SP142, sir. TMB usually I do advise in patients, although the chances of the TMB in lung cancer is less. But yes, I usually always explore the option of TMB also if the patient is affordable, sir. Am I audible, sir?
Yes, Rakesh, you are audible. I think Dr. Anshul has some network.
Are you able to hear me?
Yes, yes.
So for TMB, blood or tissue, which one is better?
So, sir, for the TMB, sir, usually I do prefer the tissue, sir.
Okay.
Yes.
And as you have, Dr. Rakesh, spoken that SP263 or SP140 is comfortable with all SP263. What regarding if we want to use atezolizumab as per IM Power 110 in a patient as a monotherapy, should we go ahead with SP263 results, or with we should order SP142 again to a patient?
So there is a data regarding the comparatively efficacy between these all markers, and the data have shown that they are almost equally good. Yes, in SP142 we might miss something because SP142, as far as I am aware, that it also stains some immune cells, other immune cells also. So yes, there is some discrepancy when comparing 263 and SP142.
So this my question is for Dr. Yashwant. So Dr. Yashwant, whenever you get a diagnosis of non-small cell lung cancer, you order a 12 hotspot gene panel or a comprehensive genomic profile based NGS,
Uh,
or only 12 gene NGS. What is your preference?
uh, if apart from logistic, if logistic is not issue, then it is always better to do comprehensive genomic profile, because we have seen in our practice that with comprehensive panel, many a time our decision changes. So for patient with no issues with fund, then it is better to do comprehensive testing. And if we are initiating the drugs like the centric and other, then better, because we need to see the, we don't want to miss the other driver mutations, like sometime in few patient we miss ALK or other. So better to always confirm with comprehensive genome approach.
So Dr. Preeti, would you recommend comprehensive genomic profile in each and every case of in affordable patients, in each and every case of carcinoma lung and
Yes, sir.
diagnosis?
Yes, sir. If affordable, then yes.
So if we have 12 gene mutation is negative, EGFR and ALK, and other mutations are negative, should we go ahead with comprehensive genomic profile before starting Tecentriq or any kind of immunotherapy? What else
If
we can get apart from these mutations like EGFR, ALK, ROS, MET before starting immunotherapy?
so, yes, EGFR, L, cross, MET, RET, there are multiple genes. If like NTRK, although the drugs is not available, I would like patient to go ahead with the comprehensive genomic profile to find out. Comprehensive genomic profile does not mean to test around 100 genes or 150 genes. Comprehensive gene profiling means testing genes by different methods, by NGS, which includes both DNA as well as RNA, so that you can detect fusions, you can detect mutations. Comprehensive gene profile means detection of mutations as well as fusions, and insertions, deletions. So comprehensive gene profile help us in diagnosing multiple types of mutations in lung cancer. So it doesn't mean testing 150 genes, but it means testing the DNA by different means.
So Dr. Soblat is there.
I am there. I am here.
Dr. Somnath, if in comprehensive genomic profile, if we get MD, M2, like these kind of mutation in which the immunotherapy does not work well. So do you see all other mutations like STK11 or MD, M2 in which immunotherapy does not work well? And according to them, in a driver mutation negative patient, you go ahead with immunotherapy.
Yeah. So the ideally comprehensive genomic profiling is to be done definitely from the affordable patient. But I am also okay with the hotspot mutation testing for the treatment purpose, like 12 gene, 18 gene, 56 gene. That is short sequence hotspot NGS like EGFR, ROS1, MET, ERBB2, HER2 kind of things. So what added advantage we can get through from the comprehensive genomic profiling? Number one is, if we need to check some other co-mutations, like as you mentioned, STK11, like SMART1, like LEAP1 kind of things, then tumor mutational burden, that is also important. That's an aid to diagnosis and therapeutic integration to the management plan. Otherwise, for the lung cancer, those are actionable driver. If we detect it through this comprehensive, through hotspot mutation, it is also fine for me. And another is the two issue. One is tissue and is liquid. Those are both are validated prospectively for the comprehensive genomic profiling. So ideally, in a ideal situations, you should do a reflex testing by blood sample also, because there is some kind of percentage, less than 5%, although they are harboring side MET amplification with high copy number, that is not identified by the tissue based by the liquid based comprehensive genomic profiling, and the vice versa. Some clonal heterogeneity was there in the intertumoral heterogeneity that does not picked up always by the tissue. So in a ideal situation, if you tell me that comprehensive genomic profiling should be done from the tissue and the reflexly from the liquid, but for the treatment purpose, if hotspot mutation identified any actionable driver, that I'm fine with this and go ahead with the treatment.
Thank you, Dr. Somnath.
Dr. Anshul, I have one question. Like Dr. Somnath, sometime we have seen that exon 20 insertions or something are missed during this 12 gene or short panels, which have many therapeutic implications, because now we have even exon 20 drug also.
Am I audible?
Yes, yes.
Hello.
Yes, Somnath, you are audible.
Yeah, so exon 20 insertion definitely is a different story in the lung cancer oncogene addicted profiling. So for exon 20 insertion, if we do for the NGS hotspot mutation, but definitely if we identify the sequence of that exon 20 insertion, like far loop, near loop, helix kind of things, then definitely comprehensive genomic profiling like CGP or broad-based sequencing would be important and identify, and it has therapeutic implications. But exon 20 insertion and the sequence also can be done in the sequence that like oncomine focus, like others hotspot mutation NGS, that doesn't always necessarily to do for the comprehensive genomic profiling.
Okay,
Dr. Somnath, I have one question. You said you do solid tumor NGS followed by liquid NGS, reflexly liquid as well.
Yeah. Ideally, in an ideal situation, that should be the norm.
No, what additional advantage that liquid is going to give after solid NGS?
Yeah, that is I am telling, there is an 20 to 30% discordant rate between tissue versus liquid.
No, but that is when liquid, the things which are missed by liquid can be picked by solid. So when you have done solid, then why liquid? Usually solid is more sensitive. It picks up most of the things which is not picked by liquid. If you have done solid, then
I'm telling there is some disadvantage of tissue and there is some disadvantage of liquid. The main disadvantage of liquid is, suppose it is a MET amplified with high copy number tumor harboring, that is not picked up by the liquid CGP.
Yes.
Whereas, and other things like some kind of fusions that you mentioned, it is not picked up by the liquid. Whereas there is intertumoral heterogeneity and subclonal evaluations is there in some kind of tumors, like particularly those who are thinking about the co-mutations. Suppose we are taking from a tissue where only del19 or exon 20 insertion positive, but on the other side maybe harboring another co-mutation. And it was reported in the literature also that sometimes LEAP or STK11 kind of co-mutation, it is not picked up by the tissue but picked up by the liquid. So in a rare situation, I think both either liquid based by followed by reflex testing or solid tumors like tissue and reflex liquid testing should be done in a ideal scenario. Otherwise, always preferred would be the tissue.
Okay, thank you.
Okay. Dr. Yashwant?
Regarding ideal therapy, okay. So it depends about what is PD-L1 level and what is PD-L1 percentage and what is the disease burden for that particular patient. Because now with IM Power 110 trial, we can offer patient Atizo and other immunotherapy drug. But if patient's disease burden is very high or symptomatic, then general and there are chances of hyper progression in initial 2-3 cycle 1-2 cycle. So I sometimes use chemo even with very high PDL1 with symptomatic patient chemo plus I. And if patient has more than 50% like TC3 group of Atizo, then I give you single agent immuno.
So, is hyperprogression is common while using Tecentriq or any other molecule? So there is one condition which is pseudo progression. One is hyperprogression. So is hyperprogression is so common? Do anybody have experience of hyperprogression during immunotherapy with either pembrolizumab or atezolizumab? Dr. Somnath?
Yeah, hyperprogression is an event. In clinical scenario, if you ask me that, I seen very rarely 1 or 2 cases with the pembro, not for the atizo. And the diagnosis is very difficult to establish because we have to sit with the radiologist as well as the clinicians to define it is an hyperprogressions, because there is a diagnostic challenge between I have a lot of discussion with the radiology guy that to identify it is an hyperprogression or true progression. So the dictum is if there is no new lesions, the metabolic activity is decreased, and the mainly the necrotic component, the inflammation going on, like infiltration of the T cell, inflammatory T cells or regulatory T cells, that is commonly causes the hyperprogressions and is difficult to identify. And although my clinical experience with these entities is less, but 1 or 2 cases we we identified as an hyperprogression and treat like that way.
Hello?
Yes, yes.
Hello?
Yeah.
Yeah.
Is there the network issues there, no?
Yeah, Dr. Anshul, can you switch off your video? Actually, most of the time it is happening with your connection, I think.
Okay.
Uh,
So, now my next question is to Dr. Rakesh. So, whenever you have a patient of say, carcinoma lung, you do MRI in each and every cases?
So, I do consider if in a symptomatic patient, sir, I do usually consider do the MRI brain metastasis. And nowadays, I do also consider doing MRI in a non-asymptomatic patients because it in a driver mutation positive patients, it usually helps me to choice a drug, whether the brain metastasis is already present or not. So yes, in my clinical practice, I do.
So, so whenever you get a brain metastasis, you go. How do you proceed? Like you provide the radiation to all those patients who are symptomatic and who are asymptomatic, both of them, or only for symptomatic patients?
So in a symptomatic patient, so I do usually suggest going for the brain radiation. In a asymptomatic patient, it depends upon the what kind of driver mutation they are having. In a EGFR mutated, yeah, all mutated patients using osimertinib or the lolatinib, I do not suggest asymptomatic patient going for the radiation. I usually go with the TKI alone in these patients, sir.
Dr. Preeti, whenever patient receive radiation, so do you start immunotherapy? Now we have data to use immunotherapy along with radiation in carcinoma cervix. So should we start our immunotherapy along with radiation, or if a patient is having PDL1 high more than 50% and having pain meds? So the patient is going ahead with radiation therapy, Wolverine which is 30 near about 30 gray. So can you start our immunotherapy along with radiation, or we should need a gap of after completion of radiation therapy?
I usually keep a gap of around a week because radiation therapy itself causes cerebral edema.
Uh,
It I'm sorry. The radiation therapy itself causes cerebral edema, and so that the patient to settle down, have settled down, I usually keep a gap of a week.
okay. So we usually keep a gap of a week. So in chemotherapy, so now our practice is going with the immunotherapy also.
Yeah,
So,
Dr. Anshul, I'm Dr. Gaurav. I'm radiation oncologist.
okay, sir. Yes, sir.
Yeah. He actually gap is right, around 7 to 10 days gap. Edema will subside, and radiation also upregulates PDL1. It has some immune system also effect. Radiation has some immune effect also. So it will actually help the patient.
Okay.
And
Thank you.
symptomatic patient, we need to give radiation actually to improve the quality of life.
Yes, sir. So
Please
my next
proceed.
question
Thank you.
from Dr. Yashwant, he presented the data of Empower. So what is your opinion on OS and
We know that in our practice, the mutation negative patient, they are still, their prognosis is still worse than our other mutation positive patient. But I think the immune phenomena, which the patient with PDL1 more than 50, they do well with immunotherapy. So patient with more than 50% PDL1 TC3 group, they do better, and their data looks more promising.
so we have now three kinds of immunotherapy. Although in first line we have pembrolizumab, atezolizumab, campilimumab. So which immunotherapy you prefer? Either atezo or pembro in cases of high PDL1. I'm audible.
Yes, 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 Dr. Hamza.
So which
Yes. So
immunotherapy you prefer? Because you have now the cost of immunotherapy is same for a year in India for both
yes.
atezo, pembro, and campilimumab is not available. So how do you choose your patient?
So I think we can use either one. The data for Atizo, like we have, it can be used for across all the platforms. So and Atizo, other benefit like PAP and other thing, they have now improved. So either one can we can use, and if more than 50%, many a time I have seen hyper progression with Pembro. Not experienced yet with Atizo. So like either one is okay for me.
So, Dr. Somnath, what is your opinion? Do you prefer any kind of immunotherapy? Dr. Preeti? Dr. Somnath, Dr. Preeti?
Yeah, I'm here.
Yes. So, Dr. Somnath, how do you choose? Like all the patients are affordable.
Your voice is breaking, Angsur.
Dr. Somnath, Dr. Anshul is saying that which PDL1, Atizo versus Pembro, which one you will use for patient high with high PDL1, and
Yeah.
why how Atizo is different from other.
Yeah. So that if PDL1 is high, I think we can use both of them. But if you select the patient to more favor for the atizo, that I will prefer those who are particularly elderly patient, those who are multiple comorbidities, and those who are liver mets on the baseline, and particularly non-squamous histology with high PDL1. I will prefer for the IMPAR 110 like of protocol with the atizo plus minus platinum, and other rest of the cohort, both options is true and correct and perfect for me. Either atizo or pembro can be offered, but for the particularly this subset I prefer atizo than the others.
So yes, so in IM power 110, so 17% of the patients who are of liver mets, and they have already stratified against the liver mets patient with respect to KN024, KN042 study. So and liver mets, atezolizumab, we have data to use atezol in liver mets. So my next question is,
And also non-squamous. Most of the patient was non-squam histology.
yes, no. So, regarding the safety issue, so we have immunotherapy toxicities with all the immunotherapies like atezo, pembro. Do you consider any kind of in both atezo, pembro, or nivo the immunotherapy which causes less immune-related toxicities? Dr. Somnath?
Yeah, for the side effect profile, I think both are all are of almost similar. The typical IRE adverse effect is typically seen after 3 to 4 months of therapy. Immediate reactions kind of things is not so common in the all subset, and thyroiditis and most of the asymptomatic asymptomatic hypothyroidism, some kind of colitis, pneumonitis was seen in the both atizo throughout the atizo pembro or nivo ep combinations. And but the other side effect like nausea, vomiting kind of things, and some kind of hematological toxicity, I think it was not directly related with the immune checkpoint inhibitors. It is contributory effect of initial chemo was given or not, for that is part. Otherwise I think all our side effect profile, it is good to go ahead.
Yes. So now we have most of the patients are EGFR positive and some are ALK positive. So after giving osimertinib, previously we don't have lazertinib or amivantanab. So next option, if your patient we have started on osimertinib, now the patient get progressed on osimertinib. So how to go ahead, Dr. Preeti?
The patient who has progressed on first line osimertinib on EGFR positive non-small cell or adenocarcinoma. You are asking this question, no?
Yes, yes.
So I usually go ahead with a repeat biopsy of the patient and find out whether there is exon 20 insertion mutation or whether there is this MET amplification, and I try to add on usually a chemotherapy.
So
If there is no driver mutation, another driver mutation which might help me, then, or there is no small cell transformation or other thing, then I try to add chemotherapy.
this and patient, if Dr. Preeti, patient has further exhausted other option also, like patient progress on TKI, then 1-2 line of chemotherapy is like other mutations are exon 20 insertion, MET, other all are negative. Then and patient has heavy burden disease. Then what do you think that any targeted or immunotherapy we can add for patient with baseline EGFR positive in earlier
See,
biopsy?
yes, yeah, we can see the Empower 150 study, which says that atezolizumab might be the only immunotherapy which may help in driver mutation positive patients of non-small cell lung cancer. Rest we know that immunotherapies usually don't work in such type of patients. So in Empower 150 patients, there has been improvement in overall survival with EGFR ALK positive patient as well. So if I have to add on immunotherapy or there is high burden of disease, I would like to add atezolizumab.
So you will add atezolizumab alone with chemo or with bevacizumab?
APCB regimen, ABCP regimen, atezo-bev chemo.
Okay. Dr. Somnath, so how is the ABCP regimen? I think you have used it
Yeah.
in multiple patients. So how is your experience of ABCP regimen?
Yeah, for the ABCP, definitely for a fit patient, those who are very much without any comorbidities and younger rather than the fit patient, because it is in 4 drug combinations along with these. And most of the cases, my selection would be ABCP, those who are concomitant KRAS mutation positive, like non-driver but KRAS G12C or non-G12C variant that is relatively doing well with the ABCP kind of things in the first line settings, definitely, and non-squamous histology also. So these are the subset that if we ask me that your ABCP in the first line, then definitely those who are fit with KRAS mutation or any co-mutation positive like LEAP or STK11, then I'll prefer for the ABCP irrespective of PDL1.
And after progression on EGFR?
After progression of EGFR means when first generation, second generation, or third generation TKI.
Yes. After third generation TKI like osimertinib, progression on osimertinib.
Yeah. So after progression of osimertinib, if you ask me that exact choice would be ME chemo or ABCP, then we need to direct head-on comparison between Mariposa 2 and IM Power 150. That doesn't I do not have. We do not have. But it is an cost trial comparison that we have seen that ME chemo will be the better options, those who are progressed on osimertinib, because if there is no small cell transformation, definitely we have to look for the biopsy and see the histological transformation. If small cell transformation is there, definitely etoposide chemo is with the gold standard. Otherwise, if there is an no kind of progression, histological transformation, my better choice would be the ME chemo or ME plus LAZA. But definitely, if we extrapolate the data from IM Power 150, those who are in subset cohort who included in this study, those who are EGFR mutation positive, like DEL19 or L858R, or some uncommon mutations, those who are progressed on osimertinib, they are also included. Those are progressed particularly on TKI, not osimertinib. So, so that is also a subset that on median PFS of 5 to 6 months was there, and definitely is an options for these kind of patient. But the more robust data with the Mariposa 2, that kind of thing. So both option is correct, but preferred option nowadays will be the ME chemo.
Nicely summarized by Somnath, I think. So I think we need a head-on trial, amivantamab versus ABCP. Yes.
In a bulky disease patient, not a driver mutation negative, having a bulky disease, should we add atezo-bev or should we go ahead with only atezo with paclitaxel or PEM carbo? Dr. Rakesh. So if he's not there, Dr. Yashwant Kashyap.
I'm there. I usually go with the atezolizumab, bevacizumab, and paclitaxel. Usually, my preferred choice.
Okay. So this is in IM power 150. So should we, what is the extra added benefit in case of bulky disease?
So on the bulky disease, the bevacizumab and with the immunotherapy, it goes the better response rate. And the median duration of response rate is also good if we go with the combination, complete combination.
Yes. We have more median OS rate and overall response rate is more with the synergistic effect of bevacizumab in IM power 150. So this is the summary that we have a lot of trials now. So IM power 010 is in adjuvant setting. IM power 110 in atezolizumab monotherapy with high PD-L1 expression more than 50%, and IM power 150 in which they have used atezo with BAV combination in non-squamous histology. So it was a nice discussion with all the panelists. I thank all the panelists to enhancing my knowledge and for a good discussion. So thanks all, and I hand over the screen to the organizers.
Thank you. Thank you.
Thank you.
Thank you so much, Dr. Anshul, and our esteemed panelists for a very engaging discussion. With this, we come to the end of our session.
Ms. Achal,
Yes, sir.
I think there is one query in attendees. Dr. Prabhakar has raised a hand. Can we take that query, please?
Of course, sir. I'll just unmute Dr. Prabhakar. I thank all our faculty members, our chairpersons, and our audience for joining in. Special thanks to our industry partners, Roche, Intas, and Edley, for making such discussions possible. Thank you so much. We look forward to welcoming you to our future sessions of BMC Oncology Webinar series. Have a good night.
So much.
Good night,
Thank
good
you,
night, Achal.
everyone.
Thank you, everyone.
Thank you,
Thank you, everyone.
Thanks, Dr. Papa. Thanks.